Okay, assalamu alaikum wa rahmatullahi wa barakatuh. To the live, we're going to QASSIMI, inshallah. For me, with me I have Dr. Hussein Al-Amri, procedure analyzer, device expert Mohammed Egrid, panelist Aram, Raed, Samih, please. So they say the proof of pudding in what? In eating, صح? So we heard lots of theories and steps and talks. People, I like now theories. Too much people talk about theories. Let's see the practice. We will go to a QASSIMI hospital, which is very advanced hospital. They have everything. And the case is about السلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله وبركاته.
1000.
My dear friends, colleagues, it's our great pleasure again to be hosted. And congratulations for the 5th edition of GIS. Quite proud about the opening ceremony yesterday, by the way. And really great arrangement from the organizers, from the doctors, colleagues, Dr. Fawaz, and the rest of the team, certainly. Actually, we have an interesting case today. Before that, I will not go through all the names as usual because I have really some kind of headache, first of all, because I had 4 hours spending on the road because of the bad weather today. But we have a fantastic and wonderful team here around me. So please be prepared for a nice case and do not hesitate to raise your suggestions. And I will be sharing with you the case in a moment.
So thank you very much. Thank you very much,
Yes,
Arif. This is Abdullah Shihab. With me here in the panelist, I have procedure analyzer, Dr. Hussein Al-Amri from Saudi Arabia, Mohammed Egrid from United Kingdom. Panelists from Iraq, we have Aram Mirza, and we have Raed from Saudi Arabia, and Samih Lawand from Saudi Arabia. So the audience already had enough theory on how to manage calcification, coronaries, and the complex. And we have, of course, Hadi, subhanAllah, just jump as all. As well, Hadi from Jordan. So we heard everything about, complex PCI and calcified and intermediate, how to manage, how to modulate that based on all the algorithm available. And I said to them, تجربة الحلو في أكله, the proof of pudding and eating. So today we're going to Al-QASSIMI, which is really advanced hospital. They have all the tools. And the cases, as you're going to see now soon, is really a complex, reflect what we see on day-to-day life. And then the objective of this is going to be how to assess that lesion, calcified, intermediate, what imaging we're going to use, what tools, and then how to modify that lesion, and then how to optimize your PCI at the end. So let's go to Ahmed and Arif and take us through the case, please.
Thank you, Abdullah. And without any further ado, because we need all minutes we need, Dr. Islam, please introduce to us this interesting case.
Yeah, thank you, Dr. Arif. I'm Dr. Islam. This is actually a lady, 66 years old, female, and she is a BMI up for 24.6. She has hypertension and diabetic type 2 with insulin dependent at the moment. She presented to our facility on 11th of this month with ACS unstable angina. She has very significant past medical history of systemic lupus erythematosus, fibromyalgia, secondary Sjogren's syndrome, hypothyroidism, hypovitaminosis D, and she has a recent spinal surgery 10 months back. Next slide, please. So actually the significant labs what we found is counts was 1.8 due to her autoimmune disease, which improved with pulse steroid therapy to 4.5. Her creatinine 86 with EGFR of 47. On presentation, troponin was 67, jumped to 184 with minimal leak. Her lipid profile are somewhat acceptable with total cholesterol at 3.8, with glyceride 8.9 and LDL 2.02, HDL 1.74. Her TSH is good, acceptable 4.14, and CRP is 4.6. Next slide, please. So this is the X-ray, which is no cardiomegaly. The ECG has no significant ischemia, and the echo showed good LV systolic function with inferior posterior hypokinesia with no valvular leaks. So based on this history and presentation, and she has a typical chest pain, although she has no significant ECG changes, we actually put the patient on the table for coronary angiography. Next slide. So we were surprised by the angiography because we were not expecting this. What we see in the left system, actually, it is a calcified distal critical bifurcating lesion, Medina 111, and the middle AD is also heavily calcified. In this view, we can see this, the LCX ostium is compromised. The OM branch is a large branch with a severe proximal disease. And we have a tendon lesion, more distal, which extend to the next bifurcation. Next, please. Then in this view, actually, you can see the more criticality of the left main with the mid segment of the LAD severely calcified with bifurcation lesion of this large diagonal Medina 110. And she has, actually the right system is small and severely diseased also. Next. Now I will actually why we decided to go for this complex case PCI rather than cabbage. I would like to give over to Dr. Ahmed Khashaba to explain more why we put the patient for this complex procedure.
Thank you, Dr. Islam. Dr. Ahmed.
Yeah, we calculated the risk profile for this patient. The PCI risk according to the Centix score 1 is 48, which is a little bit high, of course, and Centix 2 score is 21.9. Her surgical risk according to Euro 2 score is 6.12. But however, next slide, please. Despite the fact that the surgical risk is a little bit lower, of course, than the PCI, this didn't take into account several risk factors of this patient, including the severe SLE, the steroid therapy, leukopenia, which makes the post-operative course from the infectious point of view is very drastic. Fibromyalgia, also Angiogran syndrome, hypothyroidism, vitamin D low, all of these factors are not accounted for in the Euro score 2. And this made our surgeon a little bit hectic, hesitating to go for surgery. And next, and the heart team decision for a long time concluded the procedure to be a high-risk PCI with or without mechanical circulatory support. Next. So the strategy for today, we had an ultrasound-guided right common femoral access for keeping a left ventricular pigtail catheter to measure the left ventricular end diastolic pressure, which turned out to be 8, and to have it as a backup if we decided at any time to insert an Impella catheter there. TPM also port access only, not in place, but access only is there, just in case we need it. The procedure will be done transradial with a cylinder 7 French radial sheath and an EBU. Can you go back to the slide, please? An EBU 3 pipe. Start with OCT imaging. We will prepare the LCX and insert the stent. Then another OCT run for the left main LAD and a strategy of a provisional one from the left main to the LAD.
So, Dr. Abdullah, thank you, Dr. Ahmed. As you see, it's quite complex case due to the clinical presentation and back history. So there's a lot to be discussed. Certainly, we don't have that much of time, but I would be more than happy that you, as panel, to discuss what options, what other could have been done for this patient. Meanwhile, Dr. Ahmed started already wiring the LCX and do a run of OCT. So, and we have finished the mid LCX and we are at present with a wire in the LAD. And after imaging the LAD, we found out to have some significant lesion in the middle AD and the ostial LAD. So we are here now with a CSI to continue further sanding of this LAD ostium after sharing with you the OCT image. But meanwhile, you can add your comment upon what we have presented now. And we will start maybe doing the sanding or bleeding this ostial LAD, if you don't mind.
If you just allow us 2 minutes, Arif.
Sure, sure.
Because really, the whole point of life is to see step by step. I mean, that's the whole. I mean,
right.
So I just want to ask Dr. Hussein Al-Amri, because he's going to analyze. And I think this is a case different than what we saw 10 days ago. But anyway, Hussein.
Yeah, this is the backup case. Unfortunately, the first one was not possible to join us today, so this is the backup case.
No problem. It's good for us. Hussein, analyze for us according to you what.
Yeah, I think from the angio you see it's a true left main bifurcation. It looks complex. The ostium of the LAD is involved. The distal left main is involved, and it seems also the ostium of the circ is involved. Definitely, we need to see the OCT images to see what's the MLA of the ostial circ and how complex is the involvement. It will help us to decide on the bifurcation anatomy and on the strategy. If the ostium of the circ is not involved, I will just go with one stent strategy, which can be upgraded to 2 if needed.
So, Mohammed, you saw that device they mentioned here, OCT, and they mentioned ROTA. I mean, you want to maybe comment on that?
Yeah, thank you. Hi, Arif. Hi, Ahmed. It's a great case, actually, different to what we've seen.
Good to see you.
Yeah, thank you. We could use either, to be honest. I think with the size of the artery, probably orbital atherectomy may be the better choice, so you don't have to upgrade the burr. Orbital atherectomy, if you start at a low speed, you get any artery that's less than 3 millimeter, you could use it. When the artery is bigger, then you go to the higher speed, which is 120,000 per minute, which gives you a bigger lumen. So a case like this, probably orbital atherectomy is really a nice choice here. This case really raises the alarm in different ways, in the way that the severity of the left main stem in a left dominant system, the lady is on steroids and she's got Sjogren's syndrome, she's got different things. So it really has to be handled in the most efficient way and the least manipulation way, if you like. So I think orbital atherectomy probably would be the right choice in here. And Dr. Arif used a very nice word, which is sanding. This is the difference between orbital atherectomy and rotablation. You have to take your time, do it very slowly, the movement less than 1 millimeter per second, and take your time to do it. And you could do it going forward and you could do it backward. One last comment about this. Also, there's a large diagonal that I think if you end up treating that LAD, you might lose the diagonal because the ostium is severely diseased. I'm not advocating doing too much, but if you are going to stent across it, I would try to just balloon it so it's safe, because it's a large size diagonal, you don't want to lose it, and then focus on the left main stent.
So we heard analyzed the coronaries, you heard the device details, how to use them, and now, Arif, you do what you plan to do, and whatever, if you feel some of the points are important from us, also maybe you incorporate.
Let me come back to Dr. Mohammed's comments also. Actually, there are quite few technical challenges in this case. First of all, where to start, where to end some would be preferring to start with the left main and then go further. Some would say, let's finish distally and come proximally. The second challenge is the bifurcations. We have here 3 bifurcations. We have diagonal LAD, OM, LCX, and LCX LAD. So 3 bifurcations, and in a non-dominant or non-dominant right. So that means really quite high risk case. Now, what he said, Dr. Mohammed, is to prioritize here, make it as simple as possible, because we cannot maybe do a plastic surgery in this case. We need to do the most effective, the most beneficial strategy to adopt in this case, and using the technology to help us. The second challenge is the left main diameter, that mismatching between the LAD and the left main. It can reach up to 5.5 or between 5.5 and 6. So that is another challenge. CSI or rotablator, as Dr. Mohammed explained, CSI would be a good option with a speed of 120 to cover this large left main or distal left main. So all in all, this complexity, we have to take care of every step, because this is not, this lady needs to save her energy, to save her every territory in her heart. And we have to be careful. That's why we also prefer to keep an access for impeller and the rest. Are you hearing me? You have a problem with the sound?
Very nice. We hear you very well. And this show us the OCT, please. I mean, I think we can see.
All right.
Yeah.
Now, what I would show to make it quick, because Dr. Ahmed already started with distal LCX and placed the stent after imaging the LCX, and that is done already. But the OM, our strategy is not to touch that OM today. We might stage it. The circ got the 25-30%. We would be happy if we could run away or get away with it with a provisional stenting. Now the question is to fix the mid-LAD diagonal first, keeping an eye on that diagonal by wiring it probably, or just fix the left main LAD LCX.
Arif,
That is the question.
Yeah, Arif, can I make a
Just
comment,
one point
please?
about-
Just, can you hear me?
Yes.
So to me, you could do as much as you want, or you could do as little as you want. You said a very nice kind of comment. You need to go where the money is. The money is in the left main stem. There's always tomorrow, and you could come back another time. And you might find you don't need anything. I'll focus on the left main, sort that out, and everything else can happen after. Of course, if anything transpires during the procedure, you could always interfere with it. But you could spend a long time doing the LAD and the diagonal, have a problem when the left main is your biggest kind of gain, if you like. As for the size discrepancy, I think currently with the many stents that we have, particularly, for instance, the Terumo stent, or any of them, could expand up to 6. So you could take the 4O at low pressure in the LAD and the left main, then you could both dilate as much as you want. But I think the left main is your main target, should be.
Ahmed, take us through
Thank you very much.
Ahmed, take us through the
Dr.
OCT,
Mohammed,
please.
You made my life easy, because I think that is the best to tackle this case in the beginning, and then we can tackle the distality at any time. So let's focus on the LAD circumflex left main now. We'll show you the OCT run now, please.
Yes, please.
Yeah.
Yes,
From LAD
hello.
Yeah.
to left main. LAD left main,
Okay.
please.
So we'll
This
have
is the OCT for the CX. We'll skip this, but this is the, as you can see, the new interface for the Alnooryani 2 software from Ahmed. Facilitates the OCT examination and gives you a lot of measurements, as we are going to see here. This is a run from pullback from the distal LAD to the left main, and as you can see, and represented by the orange color, which a visual representation of the calcium present in the wall of the artery. To our surprise, it is not very much calcified in the distal left main bifurcation. You can find some blacks here and there. If you can go to the left main, yeah, very proximal to the left main, please. Yes, you can see. I start from the left main and downward. So this is the distal left main. This is body of the left main is nearly 5 millimeters in diameter. And then if we go to the bifurcation, this the left main, only a flack of calcium less than 180, maybe 100 or something, and then go again more distal. No, you skip the whole thing. Yeah, just go back to the distal left main and then slowly inwards. Yeah, and as you can see, this is distal left main, a very tight lesion. The area is less than 3, and the diameter is 1.8. More, please, more. As you go downward, some patches of calcium. Not occupying more than 180. So actually, this is the ostium, this is the bifurcation polygon of confluence, and this is the bifurcation with the CX opening at 3 to 5. More. And here is the tightest, from the calcium point of view, you can, 2 arcs of calcium, if you combine both together, it's not more than 180. And fortunately, both on each side, each one of them is on each side, so this makes life a little bit easier in terms of flack modification. The surprise is in the mid of the LAD, where you see most of the calcium there. Back to you, Dr. Arif.
Right. So now we can appreciate even the calcium, by the way, angiographically, if you see it, it looks a bit eccentric. As Dr. Ahmed mentioned, it looks like to be from both sides, compressing the lumen, but mainly from the upper part, if you could see, it is pressing like a nodule down to the LAD. And we need to have really an optimal result in this case. So we are thinking in our strategy to go the run now with the C side, and then probably maybe to have a better outcome or optimizing it, maybe with for deep calcium modification with a shockwave as well, and then post-dilating and then placing the stent. We will just try to modify this plaque as much as possible, to also to avoid as much as possible the plaque shifting or carina shift if possible. That is something that we cannot predict 100%, but I think we may run away, as I said in the beginning, with a single stent in this case. And the second question will be to the panels also, where you will land your stent proximally in the left main, because you see, we don't have a certain disease at the ostium of left main, so we'll try to skip that ostium left main. That's our strategy. All right, so we will go with the CSI. Yomike, continue with your comments and questions if you don't mind.
Okay, please go ahead with your whatever you planned, what you agree on, and I'll start the discussion with the panelists, and please the audience to be there. So start with Aram.
Yeah.
You've seen the lesion OCT. No, wait a second. Okay.
Hi, Dr. Arif. Hi, Dr. Ahmed. This is Aram. Well, angiographically, we have got angiographically, we have a lesion in the osteal circle. We are not sure still this is a critical or not.
Are you a little?
So to put the strategy, is my suggestion is to do OCT run to the ostium to see what's going on the ostium of the LCX. Because if the ostium of the LCS is critical lesion, at that time the strategy will change. So suggestion to do OCT to see what's going on the ostial circle and put in a strategy. And I think the best thing for debulking in this case, because there is a discrepancy between the left main stem of the LAD, is either orbital atherectomy or IVL will be the best one.
Then 80 or 120?
80. We'll start.
We will go then afterwards.
I just wanted to.
Yeah, you can comment because they are working.
I just
You can economize, please.
as the first run of OCT, the fixed one, they had this dynamic angio, which is a new feature, was this Altron 2, which make it very easy.
Okay.
So you see on the angio where exactly is the lesion and what is the length of the stent. And this was not available before in the previous Altron or the, but now they didn't do it, but I think they will do it at the end. It's a very nice feature here.
Dr. Abdullah, I just want to disagree with Dr. Mohamed. I'll put my money in the left main circ. Mid circumflex is almost 5.5, and the left main is almost 6, around 6 millimeter. So I will put my money in the left main circ since it's dominant vessel. So I think this is, so let's modify the plaque in the LAD, but not left main LAD. Left main circ is the most, it's important vessel, it's big vessel, it's supply more territories than LAD. Thank you.
You misunderstood me, sorry. I said the left main itself, how you treat it, whether to the circle or to the LAD, it doesn't matter. Yes, I said the left main itself should be the target, not the circle or LAD. They will choose whatever they want to do.
Shockwave, please.
Traditionally, it's always the LAD. Even in the dominant circle, the LAD is much more important with the circles.
Let's go back to live. Tell us what's doing, Arif. What's happening now?
We are just ablating the LAD ostium. We did forwards and we are going now backwards at the speed of 80, and we will escalate to 120 when we advance it once again. You can hear the sound change.
Yeah, the pitch changes here. And one of the main differences of the CSI versus rotor ablation is that it's a bidirectional ablation. So you ablate while you are moving forward and backwards and at the same time. The other thing is that it facilitates, doesn't occlude the lumen, so you are able to, as Dr. Arif is doing here, you are able to check your lumen afterwards. The third and the most important in my mind is that it changes the wire bias, it avoids the wire bias, so it ablates in the upper wall of the artery while you are pushing in, and ablates in the lower wall while you are pulling back. So this is a good advantage of this device.
Muhammad, you want to?
Yeah, I mean, I
elaborate?
agree. The main thing is just to do it slowly, take your time, because it's not the same as rotablation. You could do it forward and backward. Incidentally, rotablation will be soon coming out with the burr, with the diamond front and the back. So it's not going to be any more of these, and so it probably any burr will not get stuck anymore. So yeah, you do it slowly. And as you can see, even this with big artery, you have to start with a low speed so you don't affect the artery first, and then you could go to higher speed later on. As we saw, the lumen was quite small. Important, very slow,
We just changed it
and
now
very
to
simple.
120. We finished with the 80 and we changed it now to the 120.
So this does about 25 seconds, then it will give you the beep. I don't know if you will hear it, and it tells you to stop. You should not do it more than 30 seconds, but 25 seconds you stop and let the artery again rest for another 25 seconds, then you start again. You could always override it,
Yeah,
but you
the
should.
bump gives you the automatic beep, so
Yeah.
it grabs your attention to the time limit.
So there's the glide fluid that's to drop it during the burring and during using the Dynaglide or the glide itself. And this has got some eggs and some olive oil. So you have to make sure that the patient does not have allergy. I don't know if in the United Arab, do you guys use the Rotaglide? Is it available? In Europe,
It's already
we don't have it.
Yeah.
It's not allowed, but this is allowed, and I'm not sure how the discrepancy. Rota, we don't have the Rotaglide, which got eggs, and this one is allowed, and we could use it. It comes in a 250 ml bag, and there's a certain pressure on it. If you're burning too much, in theory, you should not do this more than 6 minutes, because the orbital atherectomy, particularly in resistant lesion, could disintegrate. There has been some cases where the tip has come off. So you really have to be efficient and quick in doing this. Not quick in passing it, but to doing it in multiple times. And you keep the glide running all the time when you're doing it. Sometimes if you come toward the end and you don't want to open another bag because it could be expensive. A little tug on the bag could give you that, because it's the weight of the bag that keeps it going. But yeah, the slow advancement is important.
So update us, Arif, what's going on now?
We're
What happened?
doing final run up backwards with a speed of 120, and then we are done with the seaside. Okay, and we have done couple of check or tests, and we have seen the flow was okay, patient, and the flow was okay, so we don't have anything to worry about that. Patient hemodynamically stable, pressure is maintained at around 120 systolic.
So Hussein, what do you expect when we do something like, this kind of debulking? What adverse things we are to be concerned about in left main?
I think the most important is no reflow. We should be really careful about that, especially in such a dominant system. The whole heart is supplied by the left system. I think it should be fast, it should be efficient, and it should be flushed very well during the procedure.
Thank you. I have a comment and a question to Dr. Mohamed. I agree with debulking here. I think when we talk about calcium modification, it's a mixed bag. So there is the cracking of the calcium, and there is the debulking, which is decreasing the volume of the calcium. In this case, there is a lot of calcium inside the vessels, going luminal into the vessel. So I think it's reasonable to debulk. My question to Dr. Mohamed, I've been using CSI or orbital basically on 80, and the traditional practice is 120 is not worth the risk. Like the benefit versus risk for the 120 is not there. I don't know from your experience, what do you think?
I mean, I don't know what about if it's not worth the risk, then it would not be in the device. But you have to be careful and really judicious how to use it. If the artery is less than 3.5, I wouldn't use it. And if you do it many, many times, you could run into trouble, the no flow. In this case, I think, talking about no flow, I think it's very unlikely, unless you go to the mid-LAD. This kind of very short lesion often doesn't give you that, but it is always possible. Using the 120 for bigger arteries is much better to give you the bigger lumen. But again, slow and take your time rather than to rush it. Because you have to differentiate between debulking versus black modification. And here you're aiming for almost black modification most of the time with the orbital, because it's a really gentle, and the word that was used, sandy, in comparison to Rota. One feature about this, just I forgot to mention, with the brakes on the orbital atherectomy. We all know that in Rota ablation, if the brake is not on, you could still activate it and it doesn't stop. This one is different. If the brake is not on, you push the button, it will not work. So that's the safety feature, is a little bit more different to the rotablation. I think also that will be changing on the rota also.
Give me another wire, please.
So, Arif, what happened here? You lost wire, or are you changing wire?
No. You have to, not yet. Not yet. Don't let me lose. The wire went to the circ, and I have to protect the circ anyway, and I'm going directly with, instead of exchanging the wire of the wire, just I'm advancing a simple wire.
Okay. We have a comment.
I have good movement.
Carry on, please. We have a comment from
Dr. Arif, in this particular case, you are dealing with the calcified left main stem, LAD, and dominant circ. Any complication happen, it might be disaster. Would you like in such a cases to pass the microcatheter distal to the LAD to give some vasodilator before doing ablation? If there is any role for giving vasodilator to prevent non-reflow? There is any data on this, or it's off-label? Dr. Mohamed?
No, there isn't. It just makes you feel better. That's all. I think take your time. Again, be patient. These cases are not something you go in and you have to really be patient and take your time. But putting the microcatheter just complicates the issue and makes life much more difficult. You could use some nitrate at the beginning, but it is all about not spending more than 30 seconds using the burr or the orbital atherectomy. The more you use it, the more debris is going to be. There's all, take your time. Patience is the essence in these cases. And this is why we run into trouble if you're not patient.
I think this step is important. Arif, tell us what you did just now.
Just exchange the wire. I advanced the wire as a workhorse wire, and it went nicely, deep distally, so I minimized my use of microcatheter exchange and whatever. Safer would be definitely using microcatheter, that is routine, but if you feel okay and your wire can cross easily, I think it's a simple step. You can go gently, and I need now shockwave, please.
Shockwave.
Samih, you've seen the case. Any comments?
Yeah.
Can I have a PA codal, please?
In fact,
just PA codal.
Okay. Look, this is a strategically important procedure, and any step that protects the patient safety will be great. And I think the plaque modification is to be gently, and I agree with you with that process. However, I still think that we should prepare the circ ostium as well as the LAD left main ostium, because at the end, this is a true bifurcational lesion. And if we only concentrate on the LAD left main and treat the LCX as a second step, I think we may be making a little bit of a mistake. I would have started with the ostial to proximal circ to ablate or modify, and then go to the LAD, ablate and modify, and then finally decide what is the next step.
Can I
We checked the ostial LCX with the OCT, and it is not calcified.
Yeah, but angiographically, it does not look good. And I agree.
That's why we use OCT.
Yeah, but we still have to make it equally good, because as it was mentioned earlier, this is a dominant circ. It represents most of the left ventricular supply. I will not underestimate that.
Okay. Arif, just tell us what's happening now, so then we have more comments from the panelists.
Go, please.
Actually, but if
so we can see, we can open now nicely the LAD ostium. It is a shock wave, actually. We are giving few pulses and pressure is going down. We have to stop, please. Okay. But it is open nicely. I think I'm happy with this.
Arif, a quick question. Why did you elect to use shockwave after the orbital atherectomy?
Okay. Can I have scoring for the circ, please?
Do we know?
Yeah, I'll tell you.
Yeah, tell me.
I'll tell you, sir. Because OCT showed me, and even angiographically, that the calcium is a bit deep there, and I may not have really an optimal result in expansion of my stent. So, and adding some more plaque modification won't harm, especially in this lady. I want to have really a good result for her for long term.
Okay, so
and we have good data in left main shockwave and ostial LAD, and I think that is safe. And I see a very good expansion even at the atmosphere of 4. And we have seen the LAD is well expanded now. I will listen to what Dr. Hari said because I feel that this circ got really something to worry about. If you look at it, it got more compromised.
Some dissection.
So I may, and we have dissection, nice dissection in the LAD now. So we may go for changing our strategy for a DK crush maybe.
I like this dynamic changes, strategy based on what you find. Great.
Okay,
So
this is scoring balloon.
The DK crush
Can
should
I
have
have
been
this
the
stuff?
first primary.
3-5.
I'll
Can
ask
you go 4-6 please?
I'll ask Muhannad here.
And I
If
need
you
a
have
4
orbital
stent,
and you have
15 or
IVL,
18.
which one you will use here?
15 is good, please.
Look at that.
8.
I mean,
Nine,
looking
six,
at what we
10.
saw with the OCT and the Oscil LED,
11.
I would still think orbital would work. And
12.
Good.
I could see Dr. Arif's point, which I think is important. He thought there's deep calcium, but we didn't have any OCT after we'd had the orbital atherectomy. But it's much better to be prepared,
stent, please.
and it doesn't hurt. Although
And,
sometimes
4 or 5
manipulation
balloon.
might add to the complexity, but it's a good step.
Watch it.
Yeah,
So we did scoring balloon preparation of the circ and it opened nicely at 4. We can see that. Okay, let's have a stent 4.
Let's just focus on what's happening now, then we'll come to the comments. So we can.
15 or 18 is fine. This is circ. I need to the circ, please. And then a 4-5 balloon, please.
So,
Non-complying.
Arif, share with us your thoughts. What's going on, and
No, now it is a routine. I mean, this is going to be just a step by step doing a DK crush. We will just stabilize the circ, and I have to go a bit faster because this is an ugly
Yes,
hematoma
yes.
coming up in the LED. I don't want to wait a lot. I don't want to inject a lot. So, but I think the flow is good still. But the patient has no right,
I'll
don't
put the
forget.
balloon first here.
so
Yeah,
please,
please.
go ahead and
4-5
we'll have more comments here from the
4-5
panelists and the audience.
15.
can I?
Yeah.
We start,
5:15.
and Ahmed, this is Hadi Abu Hantash from Jordan. We started with a very high-risk patient, and as Muhannad said, multi-vessel, and you have to focus on where the money is. The money is in the distal lift main. When you look at the distal lift main just from here, and with the OCT, which they mentioned, the calcium load there, it's there, but it's not something which obligates you to debulk, but I'm all for debulking. I don't have any problem with that. Now, what I'm saying is probably a lot of the audience, when they look at this, if you want to just to focus on the distal lift main, what would I have done? I would have done an LAD back to the lift main, mid-lift main, stenting with, of course, preparation, debulking, you name it. With protecting the circ, I understand that there's a concern about the circ. So making it simple, I think, is the bottom line here, rather than...
I think it's a simple made complex.
Yes, please.
By using especially the IVL. I agree the calcium was not significant. They could have tried with a balloon only, high pressure balloon, and then simple stent from LAD to lift main. When we say provisional stenting, it's a single stent where you can use a second stent if you need, which is the best strategy, of course, in such
Yes,
patients.
please.
And the other thing...
The
which-
OCT did not
Let's
show
go with the stent,
significant circ
Go with the
disease.
stent.
So I don't think we
6,
need
8.
DK or to make it complex. Simple is always better.
That's what I'm
And
trying to
fast.
say. That the IVL probably,
8,
it contributed to
9,
the compromise
10,
of the osteal
I
circ.
think-
It wasn't there with the rotation.
Ask the audience who would have used
11,
11.
12.
a debulking, rota or IVL.
Down, please.
Only one.
In the audience, raise of hands, who would use debulking from the start?
To me, the calcium was
please.
not really significant to use
Again,
debulking
please.
device. You could just use a high pressure balloon.
Yeah, it's a very
10,
difficult,
12.
very difficult decision to make. When you see calcium, if you try to use the balloon
14.
because of dissection, sometimes that could limit your
Down, please.
debulking technique. But you never know. But before they did it, so it's a catch-22, and I think because it is safe and it is simple to do, you might as well get it prepared. You've got nothing to lose.
Yes, please.
But I totally accept what
Yes,
you're
please.
saying in terms of looking at it.
Dr. Muhannad, dissection is part
Okay.
of the of PCI.
Let's
Sure.
take
98%
this
of PCI
But
is dissection.
what
This
I'm
is
go
saying,
with
what
that.
I'm saying,
therapeutic dissection,
if
not-
the
not
balloon
disease.
doesn't work and you need to debulk, with the dissection, it could become a
1
troublesome.
second.
Okay,
1 second.
please go ahead.
Go,
Yeah.
please. 610.
Just
12.
to second the comment
Down,
regarding
please.
the choice of
I need a 5 balloon, please.
modification, plaque modification.
Take this
So we
off,
have
please.
OCT, and we reviewed the data on OCT to say what
Both, huh?
kind of plaque we need to modify with atherectomy. So you have the rule of 5, which is 5 millimeter length, 0.5 millimeter thickness, the degree of calcium. I
Slowly.
don't think in
Yeah.
the
Don't
OCT
put the
that
wire.
they did, it meets that criteria. So, I mean, I'm just wondering whether we could have just made it simpler, as he mentioned, go with a high pressure balloon and then go take it from there.
Where?
So
Dion is fine.
again, I'm just
Stay on.
commenting on
Okay.
how they could have approached this case in a simpler manner.
You ask 3 interventionists for opinion, you get 4. Everybody will be doing differently, right?
Can I have,
I've
please,
got no issue with using the debulking here, and I think it's quite good.
5, and then I need a 4.
And it's better to be prepared and get this out of the way. If it is a higher risk using these, because it's a straight run and a short calcium, but also in the same token, the algorithm is not always a set
20.
in stone.
20.
There's pragmatism versus dogmatism. We're kind of getting sucked into this measurement and doing, there's a patient, there isn't a disease, there is a diagram. Sometimes you change your strategy based on what you see. And I think they've done a fantastic job using the orbital atherectomy. I've got no issue with that.
Muhammad, the point we did the
Usually
imaging
423. Just
in
before,
order
please.
to decide on debulking. And
Okay.
the imaging showed not a heavy calcium load in the distal left vein. And
Okay,
that's-
Arif,
First part.
Arif, how's the patient? And update us what's been happening.
Patients having a fantastic hemodynamics, and I enjoyed your discussion. And it's always good to hear that everyone, as I said in the beginning, everyone will have different strategy. This is not a question.
Yes.
And I'm happy that you have proved what I
This
said
is a
in the
5
beginning.
stent, huh? 5
So,
balloon.
yeah, I just will do crushing a little bit.
So Arif,
just to
can
make
I
sure
ask you a
that
question? What makes you decide
sir.
whether you go to the ostial left main or to leave it? I mean, actually, for somebody, I could tell you what I do, but I'm interested to know what
Small
makes you
test.
decide and how.
If it's a funnel-shaped
4.
left main, I don't go
2, 4,
to the
6.
ostium. That's as simple as that.
6.
Not
8,
disease
8, 10,
and funnel-shaped. If it's
Down,
a
please.
tubular, I may underestimate
This
if
is
I
how
don't
long?
have
8.
an imaging. I will go
8.
to the end because a tubular left
From
mains
here to here,
are more
this is
likely
16.
to be
Test, please.
diseased than funnel-shaped left mains.
This
I-
is 6.
the way-
That's
Can we
very
crush
simple.
You know, the way I see
Approach.
this discussion going is, we are
Just
wanting imaging,
opposite
right,
the
to
ostium,
guide
just we can
our
do one more
approach.
time.
Yeah, yeah.
We got the imaging, there is not a
Stenting
big
the
calcium
2, 4.
load at the distal left
that's
main.
2, 4,
We
6.
debulk,
I don't
we got the imaging, and the mid left main and the ostial left main look all right, and we are
8.
debating where to have the stent in. So,
It's not a debate.
You know, I'm just trying to figure out.
Sure, absolutely.
have
And I think this
now,
is why I asked the question. Because
wire to
when
the
you're
prostate.
deciding about the
See
left
on-
main, you have to be thinking if something happens. We do our angioplasty is very safe, but there's at least 1 to 2% chance of a problem. If you have a short left main stem shorter than 8 millimeter, I always go to the ostium, even if it's normal. Because if you have a dissection, you're going to have to put a second stent, which means you're going to double jail the circ. On the other hand, if you go to the ostium and something happens, you run that risk of deforming the stent in the ostium. There's a Khash 22. If it is longer than 8 millimeter, I could use an 8 millimeter stent if I need to, then you don't need to go to the ostium. Otherwise, go back to the ostium and make your
2,
life
5
easy.
balloon, please, or 3.
Okay.
To the left main stem, we have to put the classical teaching is to cover all the left main stem, but the sizes matter. Sometimes the first 3 millimeter is bigger than the Schmidt shaft. At that time, you should take this in consideration.
So the steps we missed, I think, been very interesting. If you can, we can focus there. Hani will take a question from just
I
keep focus.
just wanted to say that at the beginning of this case, they pointed out that this was a female patient with connective tissue disorder. And I was sitting here thinking, I bet you anything, she could have a cath-induced left main dissection. And you could end up with an SKS because Dr. Alnooryani just showed us a major dissection in the LED left main, but it's stable. He's not having threatened abrupt closure yet. But he mentioned that he'd like to work fast
3.
because of this hematoma. So I would just like to ask all of you, what would you have done if this vessel had gone down? You know, if your flow was TIMI 1 and this hematoma was occluding your vessel now, would you go for an SKS? Would you go for 2 stents?
Yes.
And
No,
I see
I
you're
would go with
using
the
a
direct
large cath.
stenting.
Yeah, SKSS, I mean, as you said, that's the old fashioned. We do it, of course, for
Old-fashioned.
emergency. But
Yeah,
yeah.
I would go for mini crush. It's easier, it's simpler, and faster. As long as I have a balloon in the left
Can do a
main,
kissing
I
if
can
you
go
want another,
straight to the circ,
or
open it,
Oh, no,
and
no,
then
just
open
leave
the LED,
Open the slots
left
only.
main. Yeah, I will go to mini
10, 12, 14,
kissing.
16.
16.
Down, please.
Really, the idea was, you know, as I said to you,
No,
this
you
is
can do a
Al-Qasimi
kissing
Hospital.
at,
They have
4
all the
and 4.
tools, and they're using this all the time. It's
Let's
not
have 2
something they use it
40s.
for our live case, and showed
Well,
us
you
how
did for-
safe to use these tools. That's the whole idea. I know our approach different, as Dr. Mohammed said, but, you know, just comment on what you've seen today. And is that fine? You've seen the safety and efficacy of these devices. I think it's been in a safe hand. I think it's nice
I mean,
to see
I
it.
think
How many would have committed at this point to do a DK crush, actually? At this particular point?
Because he changes strategy. You
I know,
remember,
but
based on
how
what
many
he
of
found.
us would commit to DK
If
crush?
you, I mean, I don't know.
I was going to say, to me...
You know, there is nothing right and wrong in intervention. You
Yeah.
can start with a strategy and change your
of course.
mind.
But
what
I mean,
he's
at this
doing
point,
is right.
at this point.
What you are advocating or what I'm saying is also right.
Exactly.
You have evidence to support what he's doing,
course.
and what you are saying and what I'm saying. So anything you choose
Another one.
is definitely right. It's not wrong. Nobody says what he's doing is wrong or not appropriate.
Another foot.
What he did, debulking is right. It's his decision. Doing it, you know, DK crutch is right. The way he's proceeding is right, as long as the patient is stable.
Totally agree.
Once he's
But-
unstable, then your strategy will change to just simple stent from LED to left main, then deal with the circle.
Sure.
Okay. You want to?
Frankly said, if I may add something, I mean, I always go for DK crush when I have large side branch at risk, and I don't want to lose that one. And I can do a normal kissing, and you know, I just place a stent across it and do a little bit struggle afterwards for recrossing. I mean, not necessarily DK crush, a usual standard. We can recross at any time. So that is something safe to protect my side branch without having jeopardizing.
Yeah, I have this neck.
Because I had dissection there, and I don't want to risk you like a culotte or something. DK crush is quite safe for this kind of, compromise in the flow and this kind of anatomy. Thank you.
Yes, please.
This is a very nice case, obviously, but many of us most likely will not go for atherectomy for left main bifurcation because the calcification is not so significant, and you'll most likely do a very good job, especially if the wires pass easily, also with the balloons. I mean, understanding that atherectomy nowadays, even in the US, dropped down to less than 5%. So, I mean, I don't think
Let's
we
go,
need to give the
please.
impression that
2, 4,
every
6.
calcified lesion
2, 4,
need to
6,
be
8.
rotablated
8.
or done atherectomy on it.
Both at
But
8.
at the end of the day, we return
Down,
back
please.
again to the same strategy
Stenting,
with stenting. The
423.
two major arteries look very, very large, actually.
Yeah.
You don't want to lose them. And especially when you do atherectomy, sometimes plaque shift may happen, and then you start losing the
Yeah.
left circumflex.
Yeah, that's a nice comment, but let's comment on what's been happening in front of us. Is this the safe way? Is it the right way? That's what I wanted to really most comment.
I have a comment.
Very nice.
Actually, we had the criteria for atherectomy from OCT. So doing atherectomy
Yes.
was not wrong in the first place.
The sticky
Second,
balloon.
doing
Why?
atherectomy in bifurcation lesions actually reduce the plaque shift.
Great.
Reduce
Can I just make
the...
a short comment?
Look, we are dealing with a distal left main
Okay,
disease.
423,
And
please.
whether we
423,
use the
423,
rotablation,
Sky
ablation, or just ballooning, plaque motion is going to happen. And it's going to involve the less affected osteum, which is the circ. And in my opinion, this circ was diseased from the beginning. And it was liable to get worse. And this is why the policy should have been to be protecting the left main, the circ, as well as the LAD while doing the left main. And this is, I think, the right path.
I think this is what
Chairman,
they are
I
doing
have-
at the moment. Honey?
Yeah, just one last point, access. Because if any patient would be more suited for radial regarding bleeding risk, it would be this lady. This is a radial case. But however, I'm quite happy he's not me and that he's going femoral and using
Yes,
large
please.
cath. But
He's radial.
I would do my femoral access
Yes.
here, ultrasound guided.
They do that, yes.
While I'm shivering.
Yes, they do that, yeah. Just
I have
please.
two,
They're real.
questions to Arif.
Yes, please.
Number one, he put the background using of
Okay, ileocrania, please. Ileocrania, please.
mechanical assisted device. So he changed his strategy. Is it the time to use
Ready?
the mechanical
Inject, please.
support? Number one. Number
Inject,
two,
please.
Ashraf.
he had proximal LAD dissection and perhaps
Ready?
hematoma.
Inject, please.
Is it safe to do kissing balloon at this stage?
Can you away from the
Okay,
process?
mechanical support, Mohammed?
No, the other direction.
There's
Just
no
gentle,
indication for
gently.
mechanical support in here. And
More
what they've done
tests,
also, they
more
put
tests.
a big tail in the left ventricle. And it is a
Test.
normal left ventricle, so there's no indication
Okay,
for
that
mechanical
looks
support.
fine.
Now, if they
Test.
had a complication, they are ready.
One
I would,
cranial,
you know,
please.
this is not a case for mechanical support.
Take
As
that
for the
one.
hematoma, I'm not sure the injection wasn't as hard. There
Yes.
might have been some dissection with the balloon, but that doesn't worry me at
Yes,
all.
please.
It's just, they've got wire down the artery, so
Okay.
you could do anything. If you're suspecting
No,
hematoma, cutting balloon would
let's
be your
take a
best bet.
screening.
Use a cutting balloon to empty the hematoma and you put a stent in.
Okay,
What
that's
I
good.
wanted to
Let's
say,
go.
Abdullah, here,
Can I see PA
Abdullah, the
code,
DK
please?
crush
PA
here
code,
is a
please?
wonderful idea. Just because of the dissection in the proximal LAD, the high-risk
Small
patient,
test, please.
I would have stayed with the provisional, even with the little compromise of the circ,
Test,
and then
please.
deal with it. I mean, what's the big deal? You always can recross
Test.
and put a stent and do a reverse tap. It's not a big
Two,
issue.
four, six,
Yes,
please.
always do what you are, comfortable with. And,
Exactly.
6, 8.
Exactly.
This is what I said. 3 interventions will give you 4 opinions. I'm sure in this whole now, everybody will be thinking, I'll do it different. This is the nature of what we do.
14.
I just want to add one comment. I often avoid any crushing technique if there's calcium and debulking.
Done.
No matter what
Done.
you do, there's
Take
always
this wire.
residual calcium, residual disease. So when you add multiple crush layers, plus don't forget,
One more,
DK
please.
crush has the evidence, but 7%, even in the people who did the study themselves, were not able to recross into the side branch. So keep that
Lot
in
of
mind.
bubbles.
so
Okay, 5.
update us, Arif, update us, please.
Again, please. Can you go? I'll tell you. I'm just placing a stent, a 423 in the left main LAD ostium. I may need another stent distally, but let us finish this one. Down.
Which stent did you go for, Arif? Which make?
It's a Sky Point 4 Sky
Okay.
Point.
So Zions.
Yeah.
It's making flaring.
Let's focus just a few seconds on what's going on without...
So I'm sure the audience is familiar with DK Crush, 17 steps that you have to make, which is, it is,
That's
it
the
is what
problem.
it is.
Every year they add another
17
one.
steps. This is, if you want to make it by the book, it's 17 steps in
5
comparison to 11 for DK for Kilot or
5
a provisional, which is 3 or 4 stents. Cases like this, especially with this anatomy, sometimes what you could do, stent the LAD circ, and if you need to the left main, if you want to stent the circumflex, you could use the high frame rate to position your ostial stent in a T-way, so you know that there's no gap.
So, Hussein, with the left main, you came back to the ostial. What's the problem? Why? Some people advocate that, some people no.
I think if the left main is not diseased, you don't have to go back to the ostium, even if there's mild disease, as long as
2,
you
4,
land
6, 10.
on black burden less than 40%. You just need to leave
2,
enough
4,
space for your butt. That's all.
6, 8.
Exactly.
8.
This is a long left
12,
main. You don't have to go back
14,
all the
40
way
down,
since
please.
it was normal.
Disadvantage of going back to the...
But this is what I said about the length of the left main. They had to go back to the ostium because they have to do a kissing balloon, they have to do a pot. If they don't go back to, this is probably about 10
6, 12,
millimeter
14,
left main. So
16.
if they don't go back to the ostium, they will not be able to do a
18,
pot
18,
without
20,
affecting the normal part of the left main.
22.
So
22.
But the
Down,
problem
please.
with going back, for future.
for future, well, if the stent is
you
protruding
open
and
an
coming
eye,
back, it
please?
could be a problem, but hopefully not. I think
There's
it
no
will be
difference
okay.
in outcome, whether you leave the ostium or you don't leave the ostium. There is stenosis
So the
rate is less
hemodynamics
than
than
1%,
please.
by the way.
Okay.
So I think that one of the most common mistakes. if we
Another
have
wire,
the
please.
criteria
Pressure is
for-
not
Steven,
shown. Show the
please.
pressure, Tajam.
and we don't do
Shuffle.
atherectomy.
Yeah, don't show.
It was called
Yes, we are.
rotary regret, and here is atherectomy regret. You
Thank you.
regret not doing it after it's
Um,
ballooning.
A new
Like
wire,
this?
please. No, wire, resource.
Wire.
Can I have...
Sayun.
Open up, please. Open up, please. With the image. The window.
So what stage of the DK crush are you guys at? I could see both stents now, right?
We did the pot with a 5.
And now
And
you're going to recross to the
Now we are
circ.
doing a final kiss. Yes, please.
Hi.
Great. So for future, Hussein and Mohammed and the rest, we still have lesion to tackle maybe in future, maybe, I don't know. So how easy it is with having a stents and LAD and left main, LCX
Well,
for future?
they did a beautiful job. The 17 steps have been done over.
I'm talking
seconds
about-
here. I know, but they did
You
a
know,
very good job.
It's only
I
12.
always like to go from distal to proximal.
Okay.
It makes it easy
Yeah.
and it makes it less complex for
Yeah,
you
let's take it
in
on.
the future. And again, even when you overlap the stents, the overlap will go smooth and nice, better than when you overlap it the other way around.
But like what Mohammed said, there is that chance, though it's less than 8% or something in the literature, that you might end up not being able to do the final kiss. It happens with DK crush. It does happen.
In
with
real
DK.
time,
What final kiss?
so in real time, as I said, the people who did the procedure themselves, they came up 7%, they could not recross into the crush set.
No,
In
but I
real time registries, were 12 to 13% people are able to recross. So there is that risk, no question about it.
If you do your job, your homework well, you will cross. If you prepare your legion well, you will be able to.
We all think we will cross, but as I said, the registry and the study told you 7% and 12%. So, it does happen.
Let's see what he's doing.
So,
Balloon, please.
Arif,
3, 4, or give me a 4 semi-compliant, please.
Arif, it looks great to me.
Or three
And geographically,
semi-compliant,
at
yes.
least. I don't know by imaging, but angiographically, I think looks fine. What next?
Kissing, final kiss.
He will do the final kiss now.
So are you
I
going to
open
do,
the struts.
What about the
are you going to
lesion?
do the proximal
The
LAD?
and the circ lesions now, they are left behind. We have to.
Well, that's what I'm saying. I
manage
mean, you don't have to do it on camera,
recrossing.
obviously, but you could do it after we finish because you've got your equipment. You don't have to come in and out of even if you cause any damage to the stent, you could post dilate at the end.
Absolutely.
So-
and leave it.
Now, Dr. Mohammed, as you said, we have done the job in the left main. Now we will reassess the situation and then decide. So this was for the sake of the live case demonstration of the left main bifurcation. And we did really studied with you, shared with you the case in a nice way. Okay, 2, 4, 6, please, 8.
It's a great way.
And,
Great way.
No,
Very good job.
it's outstanding, Dr. Arif
12,
and
14,
Khashaba.
16, down, please.
So steps being great. We just want to see the end result with the imaging.
Sure. We just do the final 2 steps left, kissing and pot, and you're done. I mean, this is what I always say now. By doing DK crush, you have guys to, in the live cases, to give 15 minutes longer because it's really with all what we did, efforts to spare time, you cannot avoid. You want to discuss while we are working, and DK crush takes little time, and we were lucky that we have done everything. 4,
Yes.
please.
Yeah.
4.
Yeah. 4 balloons. Yeah.
So this DK crush in the live, I think operators should have little more time, 15 minutes more, to be able to give you the final result. Because I don't know, this is my
Arif,
experience on a couple of occasions.
Arif,
Yes.
we've seen the steps. As everyone says, he's been great.
I'm saying for the future, you should consider this.
Inshallah.
That's all.
No,
We are done here with the case.
Even by the operator who actually discovered this decrash, we've seen it, and it take longer time than you. But I think you've done a great job.
Absolutely.
So we are really happy. We just want to see the last imaging. I think that's everyone likes to see.
I have still 3 minutes if I am not.
Yeah, you
if
have.
are
You
so
have,
strict,
yes.
yeah?
Yes,
If you are
yes.
so strict.
So Arif, while you're working, can I ask you a question? Do you think the choice of stent make a difference in your DK crush?
That's a good question. I mean, it depends on a lot of, even the age of the patient. I mean, whether I use some kind of with short dual antiplatelet more, and whether there's a lot of calcium, maybe you go with more, with better radial strength, more thread thickness. Yeah, I do consider that in certain cases. It's not the same for everything, for every patient. I agree. I don't do that.
Probably, Mohammed, the answer to the question is you have to give the stent, which you can actually safely get upgraded in terms of its size. Avoid the ones which do not give you that lesion. I think that
I think the only thing is about the sizing, nothing else. Because
Exactly.
put any stent now in a box, mix them up, and hand me any of them. They all do the same, more or less.
yeah.
It's except this
Okay,
now.
ready?
The
Let's go
expansion.
to
Some of them
for-
are going a little
First, let's go
expandability, yeah.
circumflex, not this one.
Just
this
a
is
comment
discussed
about
with
failing of
14.
crossing the stent after decay. I think that the good lesion preparation and good crushing
14,
with the 1-to-1
16.
NC balloon will
Down,
make
please.
this leak a bit
Now you go,
lower,
please.
because if we are not going to do good crushing, at that time failure will be more. And on the other
Down,
side,
please.
the beauty of the
I'll
decay
advance.
crush is that
Yes.
you will not have any geographic miss. Definitely, you will cover
Let's
the
go
ostium of the
1
LCX.
second.
So preparation and good crushing will be the key point for this one.
This is the thing about bifurcation. As I said, master one or two techniques, and you could do
2,
them.
4,
It's not a
6,
problem.
please.
You do. I don't do decay crush. I just find it. There's, it's not something. Everybody
Okay,
does it
10,
differently, and everybody get a
12,
good outcome.
14.
Master 2 or 3, and that's more than enough.
Down, please.
So he did the final kissing.
So yesterday, October bifurcation, we heard from the experts, and today is practiced here using imaging. So this is the, I think,
Let's go one
when
by
you see
one.
things in practice, make it much.
Dr. Arif, would you
5
do
balloon, please.
a report? I think they will do a report.
Report. The people like report.
Take this balloon.
We can do image and then if you want to, but I like
Yeah,
to do
like-
the part first.
Yeah, show us the imaging.
If
yeah.
you
I
are-
mean, in theory, the report should happen because when you put the two balloons, the stent becomes elliptical.
Let's have a
rather
5,
than-
please.
Doesn't make any difference. I'm not sure, but that's what we usually do. Go
No
back.
data, no data.
Yeah,
No data. Showing any clinical outcome.
and there'll never be a
Just
data
one
anyway.
study showing the laminar flow is much better, and the shear
5.
stress is more with the final pot.
And yeah,
So everyone is watching, their eyes on the last
nothing much left to watch actually.
imaging. I think they want to see OCT.
The OCT will be lovely
see the
to
OCT.
see.
I
It'll be
think
good.
another thing about CSR.
You want
It's very hard to get your bird stuck with CSR.
Okay.
Nearly.
okay,
I'll
2,
be
4,
requalifying.
6,
I wouldn't be. It's
10,
very hard. You
12,
can't.
14.
It's all about the technique.
16.
Honestly, it can, and I've seen it
much?
where the
18.
the
Down,
crown
please.
has came off, so it can.
Yes, but because it treats back and forth.
Again,
back
18,
forward,
please.
forward and backward,
Sure.
harder than.
We were having this
20.
discussion.
So they-
Burr entrapment is always rotor,
please.
So they
related.
did the report. So they,
Respecting every steps, I think,
Yeah,
is,
they did it.
is outstanding.
That's the 18th.
That's great.
Again, please.
That's the 18th.
20.
20.
عملوا كل شيء خلاص.
Down, please. Okay, your OCT people are keen to have some
Yeah.
kind of image.
Waiting
I
for
think
the new
yeah,
OCT.
that's the only thing remain.
We
Otherwise,
have both
great.
IVAS and OCT actually.
Take this balloon.
Okay, watch it. Can you open the window? Can you decolonize please? Okay. Just
So
look at
what do you
Take
expect
one
to see on
angio.
OCT, Mohammed? What do you expect to see on OCT? I mean, to say it's optimized.
I just want to see the angiogram first, so I could tell you what I'm going to see on OCT.
1 PA cranial, please.
But we need a little bit of harder injection, I suppose.
Away a bit, please.
What we need to see by OCT is the MSA. We need to see the MSA of the CERC, the LED, and the left
We need
main.
to fix that.
And numbers? Any
And
numbers?
down, please.
More
I need
than
to see
90% of the distal, of course.
One ariocoder, please. Give me an image, please.
It's
OCT,
not
please.
numbers, by the way, now.
LED?
It's in relation to
LED.
percentage.
Be
yes.
ariocoder, please. Give me OCT, OCT.
LED, yes.
That proximal LED does look to need to be done today, I think. You
We'll
can't-
do it, we'll
yeah,
do
you
it.
can't leave
We'll
it.
do it afterwards.
And the circ
But
as
we
well.
have to do it
Yeah,
with
yeah.
the bifurcation with the diagonally.
Focus on the work we did today. Just forget about what's left.
We want the
Please.
OCT.
No, but I agree with Mohammed. This is not for staging. We will finish it after this. We'll continue.
Excellent.
This lady deserves a little time.
Yes.
And this is a complex. We all agree
one
this is
you're
a
talking about.
complex. We don't want to make her go through this. We have wires in place, everything open.
Yes.
Okay, we'll satisfy you with one and show you the distal problem as well from this. Oh,
so
you
let's-
went to the circ actually. Come to the circ. You went to the circ, what doesn't matter.
No worries.
Okay, ready? Okay, let's have a shot, please.
Dr. Arif, can
Okay, ready?
Let's
Yeah.
watch. Let's watch now. Watch.
Okay.
And is this the high resolution 54 or 75?
54 it is?
54?
Distance.
Yeah. 75.
It doesn't matter.
It doesn't make too much difference, but just for
Makes only difference in 3D reconstruction of stents if you are doing 3D reconstructions.
Oh, it didn't. Did it record?
nice guide.
Yeah.
Nice guide. No, we'll go in again, please. Yeah, one more time, please.
What happened?
Can you restart, please?
It's restart.
Yeah. Okay, let's go in again, please.
Yeah, it's there.
Okay, we are going in again. Okay. Ready?
First.
Yeah, it's done.
Yes,
Yeah.
sir.
So you do lift LCX بعدين LED.
ما بنخلص.
Everybody is waiting to see the OCT. I guess it's like the room is so quiet. Everybody is waiting for
Dr.
the
Arif,
result.
would you please, can we show them the dynamic angie also on this new OCT?
Okay,
Okay.
let's see what the final results, and so we can also thank Dr. Arif and his team for great, outstanding as always, really dynamic, changing the strategies, based on what he sees. Excellent using the tools in a safe, effective way. Thank you, Dr. Arif and Dr. Khashaba, and show us the last three. Thank you.
Yeah, can we see the OCT, please?
Let's see the OCT, let's see.
This OCT, please.
We are watching.
Confirm.
Actually, we are happy to have this alternate tool with the new features of 3D reconstruction. Oh, fantastic.
Great.
We are 1 millimeter, I think, out of the left main.
That's
This
fine.
still distal LED, yes. So
We will,
this needs work.
no, this is circ. We will finish this one
sorry,
now.
Sorry. Yeah.
Can we see the ostium, please?
Sure, it's moving, my dear friend. Just give me a
No,
few seconds.
I mean,
I
stop,
have plenty of time.
stop it at the
Oh,
ostium.
as you can see, stop, please. Just remove the the markers, please. Yeah, okay, here we go. Can you go backward? So in the mid, the body is okay, for sure.
Yes.
Will a pose. Created nice.
Was the activation
That is going
manual
inside.
or?
Go back to the other direction.
Sorry, Arif, was this the activation manual
That's
or
the LED.
automatic?
That's circumflex, sorry. It's going opposite direction, the new system. I need to adjust my
It is manual.
brain somehow.
That's why it's not.
Okay,
Yes,
so
some
that-
contamination there. That's why it is not that clear. Some contamination.
we have an
That's not
IBIS
appreciated.
open. We will check it with IBIS again and control. But I can see here, it's up here. I mean, we can see because OCT may not cover the ostium. I
Yes.
have IBIS
Yes.
open here.
Yes.
And I will double check that. But I can see that our sizing was good. We have good position of the struts with the 5 and the kissing, Certainly we don't have malposition. And I can tell you maybe it's a 1 millimeter, 2 millimeter outside, but not more. We did good angiographic positioning. Here we can see a little more proximal. Yeah, here. And that's it. It's 1 millimeter. We got even the ostium actually.
Amazing.
If
Thank
you
you.
are going inside or no? No, that is in the proximal,
This
not
is
the
the
branch.
guiding. No, this is the guiding. Yeah.
It's not a branch. Okay.
Thank
Good,
you.
Dr. Abdullah. So with this,
Outstanding. Thank you very much, Arif. Thank you very much. Thank you.
thank you, sir, for your support and patience. Appreciate it.
Thank
Have a good day and congratulations once again for the nice event.
Thank you very
Thank
much.
you, Dr.
Thank you.
Arif. Thank you.